need to know who the primary.
Good morning, everyone. This is David Jorgensen with MaineCare. Thanks for waiting while we get set up. Could I ask my colleagues at Myers and Stopper if we think we have most of the participants that have registered on the line?
Yes, it appears so.
Great, thank you. Grace, while you're sharing the slide deck, it looks like we're seeing the presenter's view. It will be helpful if we can see the presentation view, if you're able to switch over to looking at that, so we can see bigger slides.
Grace, go back to where you were. And try that icon right there. Oh, I'm sorry. Immediately to the left of the slider having to do with Zoom. The Zoom size. So far to the right, bottom right-hand corner. Bottom right-hand corner. And then to the left a bit, and the icon immediately to the left of that. Yep. Huh. How do we get out of here?
That's all right. I think we can
swap presenter and slide. Try that. Yeah, there we go.
There we go. Great. All right. Well, thanks everyone for joining and for waiting for us while we work out these technical issues. I'm glad you could all join us on this Monday morning. We at MaineCare are very excited to kick off these stakeholder engagement meetings with you all, and we'll be going at this all week. You get to be the first participants, so congratulations, and we look forward to hearing your comments. To do a little bit of level setting at the beginning of the meeting, I'll be walking through just the agenda, the structure of the meeting, and what the expectations are for the meeting, some ground rules for how we'll be engaging with you during these sessions to make sure that they're productive and that we make good use of the time. Grace, could you advance? So we'll do some quick introductions of our team. We'll review our project objectives and give a brief overview of what value-based purchasing is. We'll talk through the discussion topics that were shared with you ahead of the sessions and go through the structure of the meeting. With that, I think we should start with the introductions. As I said, I am David Jorgensen, the Director of Data Analytics and Rate Setting with MaineCare, and I'll go through the rest of my MaineCare colleagues right now. Peter, would you go next?
Sure. I am Peter Kraut, Manager of Rate Setting.
Thanks, Peter. And Grace? Grace, you're on mute still.
I am Grace Williams. Sorry, I couldn't unmute myself. Financial analyst of Rate Setting.
Thanks, Grace. And Dwayne.
Good morning. I'm Dwayne Parsons, Rate Setting Financial Analyst.
Okay, thank you. Lori. I'm not sure if Lori is on the call.
All right, this is Lori Bailey. I am the management analyst for Rate Setting.
Great, thanks, Lori. We have been working with Myers and Stauffer through this project. I will hand it over to Catherine to walk through the Myers and Stauffer introductions.
Julia?
Sure, I can walk through our introductions. My name is Julian Keeler. Let me see if I can get rid of that echo. Okay. My name is Julian Kuther. I am a manager at Myers and Stauffer. Similarly, we also have Julia Kochever and Catherine Strikovich on the line as senior managers at Myers and Stauffer.
Thanks, Joanne. All right, so let's get into the purpose of the meeting today. Grace, could you advance? So the purpose of our rate setting evaluation is to develop a system for establishing and maintaining rates that are sufficient to sustain the financial viability of Maine providers, ensuring that MaineCare members have access to high quality services, and also to evaluate MaineCare's rates and rate setting system and develop a plan for the creation of a comprehensive, streamlined, and coherent system. Go ahead and advance. Today's meeting will not be to gather feedback about the rates themselves, the level of reimbursement. It's targeted towards the methodologies that drive the creation of those rates. We will be gathering input from providers and provider representatives regarding the impact that our current reimbursement methodologies have on you as providers, on your services, and on the MaineCare members that you serve. Today's meeting will be focused on gathering your comments from our discussion points that were shared. We are going to do as little talking ourselves as we can. We'd really like to hear what you're saying. So with that in mind, we will not be responding to questions other than questions of clarity about the discussion topics. But we won't be answering questions about the methodologies themselves or about the rates in order to make sure that we make the best use of our time. Go ahead and advance, Grace. Oops. I'll just say that we will be, if you do have questions, you can email us. I think our email address will be shared on a later slide. So I wanted to give a quick introduction to value-based purchasing, as it may not be a familiar concept to all of you. One of the goals of this rate setting evaluation is to identify areas where we can shift towards value-based purchasing. At a very high level, value-based purchasing is about getting the best quality services for the lowest cost available. If we want to maximize value, we have to increase quality or decrease cost, or both at the same time. If we want to maintain the same value as costs are rising, then we have to also increase the quality of the services being provided to our members. Next slide. So the ways that this works, value-based purchasing moves away from fee-for-service by finding ways to hold providers accountable for the value of care that they deliver. Value-based payments explicitly reward healthcare providers for performance relative to the cost, quality, access, and/or service utilization objectives. And at MaineCare, we have a number of value-based purchasing approaches in use currently, and future phases of work will consider alternative value-based purchasing approaches as we evaluate new methodology options. Next slide. As we're thinking of transitioning services to value-based purchasing, we'll be using this HCP-LAN framework that describes different levels of value-based purchasing. A lot of our reimbursement methods are currently categorized as this quality one. We have fee-for-service reimbursement, and there's no link to quality or value in those reimbursement models. It's simply for the volume and type of services provided. We are already transitioning different reimbursement models into category 2 and 3, and that provides incentives to create more quality, create more value, and we'll be looking for opportunities to transition more services into those categories. Advance another slide, please. In today's meeting, we will be discussing the 5 topics here with roughly 30 minutes per topic. How well do the current methodologies work for the services you provide? Does the payment methodology create the right incentives? Do you believe that the payment methodology for the services you provide is equitable to methodologies for services provided by other provider groups? Does the methodology result in administrative requirements or activities that are burdensome to you? And is the methodology consistent with value-based purchasing? Next slide. For some level setting, Myers and Stauffer's role in this meeting will more or less be that of a moderator. They will introduce the discussion questions, making sure participants keep their comments within the announced time limits, ensuring that the comments are relevant to the discussion, and they will be recording this meeting and providing transcriptions to make sure that all of the comments are captured. Your role as participants will be to, when you make a comment, introduce yourself and the services that you provide. Please limit your comments to the discussion topic that is actively being discussed. If the point that you would like to make has already been made by others, just instead of reiterating those comments, please feel free to just reference the other person's comment and note that you agree with it. Please respect the time limits and limit your comments to those related to the impact of the payment methods and not the rates themselves. As we mentioned, there will be later opportunities to discuss those actual rate reimbursement levels. Next slide. So the session is being recorded, and we will make the recording available online at some point tomorrow. And there will also be transcriptions available. We're still working through the timeline for that with our transcriptionist, but those will be made available as soon as possible. So with that, oops, sorry, can you go back one more? We've mentioned phase 2. We wanted to make sure that you're aware of the general schedule for that. We will be scheduling phase 2 stakeholder engagement meetings for mid-November. The final schedule for that should be released several weeks in advance of that to give plenty of time to prepare. And at that meeting, we'll be reviewing the benchmark report that's created as a result of these meetings. We'll be discussing the catalog of existing payment methods and recommending services as candidates for alternative payment methods. And again, if you have other questions or comments that are beyond the scope of the meeting today, please feel free to submit them to the rate setting evaluation email address, and we'll be happy to take a look at those.
And this is Peter Kraut. Before we hand it over to Myers and Stauffer for the meat of the meeting, I would make a request that if you're comfortable doing so, let's all put on the video. I mean, after 6 or 7 months of Zoom meetings, we're all sort of accustomed to that. And these meetings are obviously were intended to have sort of a town hall format and feel. And I think that being able to see one another will really contribute to the spirit that we were trying to achieve in these meetings, which isn't insignificant. So I know some people aren't quite comfortable being on camera, but if you are, I'd ask that you please do so, and I will take the first leap myself.
Thanks, Peter. And so with that, I will pass the discussions off to the Myers and Stauffer team. And again, we're thrilled to have you working with us on this, and we look forward to hearing all of the feedback that you have. Thank you.
Good morning, everyone. I'm Julia Kachiver, and I'll be leading the discussion today. Thank you so much for coming to speak to us so that we can have as much information to be able to inform our report about the methodology. So our first discussion, if you could advance first discussion question. And as just wanted to reiterate, we want to make sure we get everyone's comments. So we are limiting to about 30 minutes per discussion so that we can get through all of the topics and get as much information as possible from each one. If you would like to speak, I believe we're using the put up your hand method. And then Jillian from Myers will also be helping to manage some of the muting, unmuting functions as we go along, so that we can make sure that there's not weird echoes because people accidentally unmute or something like that that can be disruptive to a meeting. So our first question that we want to talk about is how well the current methodology is working for the services you provide. And we have some sub-bullets to kind of explain more of what we mean about that. Is the methodology transparent and easily understandable? Do you understand how your rate got to be what it is? Not the rate amount, but how the process by which it was determined. Does it create opportunities for efficiency and economy? Does it reflect how you deliver services? For example, do you typically provide a bundle of services, but you bill separately for each one? Or you bill in minutes when you never provide the service, where an hour or more would actually be a more meaningful representation of how the service is provided. So with that, I'll be looking to see, and Jillian will be looking to see if who would like to offer a comment on this question first. And please don't forget to state your name and what service you're speaking about.
Okay, yeah, if everyone could raise their hand if they are interested in speaking. I'm not currently seeing any raised hands right now. Okay, I've got a chat message from someone, so let me, if you can't find the raised hands or if you have issues, you can also feel free to raise your hand kind of in the chat button, and I'm also monitoring, those chat questions and in there. So Norma, I'm going to be unmuting you right now.
Okay, hi everybody, I'm Norma Desjardins. I'm a general dentist. Is there a lot of echo? I'm a general dentist at St. Apollonia Dental Clinic in Presque Isle. So the payment methodology, while it might be easily understandable to providers who regularly provide services to MaineCare patients, it can and does create significant disincentive to enrolling new dental providers. And unfortunately, there's a perception that the current methodology is ripe for errors. We feel that the methodology should be similar to other dental insurers utilizing codes that reflect the services provided. So, for example, when we provide a restoration on a tooth, there might be two parts of the tooth that were filled, two separate parts. And on the claims submitted to commercial dental insurers, we bill for those services as we do them, because that's what we're supposed to do according to the ADA coding manual. And those private insurers, through their computer system, then bundle that for the number of surfaces per tooth that was filled. But MaineCare requires us to do the bundling prior to submitting the claim, because I've been told that their computer system cannot do the bundling. So we've got to record to MaineCare or make a claim to MaineCare, and it doesn't really reflect what we did for the tooth. And my understanding is that it's supposed to be the payer that does the bundling of the code and then reimburses as they see fit. So that's one example of how it's not necessarily easily understandable, because an office, if they've been seeing commercially insured patients and want to take on MaineCare to help out, they have to bill differently for that group of patients. than they would for all the other patients that they see. I have more I could say, but I don't know if you want to proceed to the next question or what you'd like. And I was trying to show my video, but I don't have a button that says start video.
Okay, thank you, Norma. I've got one raised hand here for.
Jillian, Norma said she has more comments if we're willing to hear them. Julia, what do you think in terms of time management?
So, Norma, did you have more comments on sub areas that other people, if you could please mute, do you have more comments on just this question or on the other discussion questions? Because I think we're trying to organize it by question.
Okay. Actually, I have more comments on question 1, the way that you got it on the screen there.
Yeah,
So,
and please continue.
So it would make, if the methodology were more, it could be more efficient if MaineCare adopted the same billing methodologies as commercial dental insurers. Also, there are administrative burdens in terms of billing and oversight. There are parts of the claim form that some offices have to actually manually fill out. So part of the claim they can fill out, and then they have to then manually add an entry on the claim form. So then it can't be filed electronically. And one example that was given to me by other offices is box 23, patient ID account number. And it's used for internal purposes. Commercial insurers don't require a number there, but MaineCare advises that a 0000 be used, and some offices have to manually enter that. There's a big burden if a patient is covered by a commercial plan and MaineCare is the secondary. Typically, the primary insurer fee is higher than the fee allowed by MaineCare, and the balance is then written off. While all other insurance carriers accept the initial insurance claim and a copy of the EOB, MaineCare's current methodology requires that a claim be submitted. The secondary claim must, in some instances, be handwritten. So it's a time-consuming process. But it's important that these claims be filed, even though we know it's not going to be reimbursed, so things can accurately be reflected on services that were provided. And if the methodology, that last part that you have there, does reflect how we deliver services. So there's a big problem here because prevention of disease is a hallmark of dentistry. The fact of the matter is patients benefit from regular dental checkups, and that's how dentistry can be successful and has been successful for decades and decades and decades. So a comprehensive oral exam, radiographs, and caries risk assessment is important to that first complete assessment and aids in determining so many things as far as, for example, the interval of care. Some patients might need 3-month prophy, some patients might need 6-month, and some might only need an annual visit or cleaning. So what happens is if we're a MaineCare provider for patients as dental, from 0 to 21, the system does encourage a prevention of disease. And then all of a sudden, once they turn 21, it discourages that and doesn't cover for diagnostic services, for regular care. And oftentimes, if the adult can't pay for those regular services out of pocket, their disease will progress. And unfortunately, we see a lot of that. So then by the time we see adults, it's very hard to evaluate them. We're seeing them for an urgent or emergent visit. And in our minds, we operate by looking at the big picture, comprehensive care, and how can we get this person from needing emergent care to actually having health and preventing further disease. And in our minds, we have to operate, it's a whole philosophy change. And it's not really fair to the provider nor to the members if all of a sudden the provider has to switch gear and just provide urgent and emergent care for the population that is older. And so my feeling is if somebody qualifies for MaineCare, which I'm not the judge of, right? I see them, they happen to have MaineCare. Some of them have private insurance, some of them have none, some of them have both. But so I didn't decide whether or not they needed MaineCare. But now MaineCare is telling me that they're over 21, so you have to not make a big plan for them. You have to not look at them and assess them as you would normally assess all the other 21 and over year olds in your private practice. You would normally want to give those complete comprehensive care. But this person who's on MaineCare doesn't get that. And the problem is now if I just switch to, from the member's point of view, we see a lot of members who bring in their kids, a lot of child members, but we see the adults bringing in their kids who they cannot afford that first step of having a comprehensive assessment. And so they are not going to get it. They're not going to get that comprehensive assessment. They're not going to put money towards it because they're putting money towards their food or their car or their gas or their heating or their rent. And so they are just going to fall into that big gap. And then when they start to have a problem is when we're going to see them and then just provide the urgent or emergent care. So it doesn't really lend itself to prevention.
Great, thank you so much. So we really appreciate the feedback, and I think if we could move on to the next one.
Julie, I have a couple hands up here.
Okay.
First, it looks like I've got Jeffrey. So Jeffrey, you should be unmuted now.
Hi, good morning. I'm Jeff Wallawender. I'm the Executive Director at Community Dental. We have 6 offices altogether, and then we also manage the Psychiatric Center in Augusta. I will be super brief because I don't want to make this the dental show, but just so people understand that, you know, what our current methodology is fee for service for, you know, under 21 for all coverage, and then over 21 is emergency-based services, but the FQHCs are reimbursed differently on a per encounter basis. So just to kind of clarify with the, you know, is it transparent and easily understandable? It certainly is for the providers who do this on the routine, but the providers are acting as almost the insurance agent because we have to explain the benefit to the MaineCare members. And that is an increasing burden on us, meaning that they don't have an understanding of their benefit. We have to explain it. Whereas if you look at Northeast Delta Dental, they have a whole team of people who are there to, you know, consult with the providers and the members to understand their benefit. And this is, you know, a huge burden on us. And then a good portion of the dentist time and the front desk time is, you know, explaining that that benefit there, which is pretty simple for under 21. But when you get over 21, it's pretty complex and definitely not transparent. So that's going to be all I have to say for now, but I'll give other people a chance.
Great, thank you so much.
Okay, thank you. So I see. Okay, I see here we've got a few call-in users, and since they may not be able to raise or lower their hands because they don't have an audio connection, I'm going to unmute them. Call-in users, if you could let me know if you would like to speak, that would be great. Okay, any call-in user that would like to speak? Liz, I know you have your hand up, but I don't see an audio connection for you, so you might be a call-in user.
Hi, this is Liz Conley.
Hi, yes, we can hear you.
Okay, good. I would like to speak a little bit on the questions. Of course, I'm coming from a clinical laboratory, and the payment methodology that we're currently using is easy to understand because it pretty much follows Medicare payment methodologies for the most part. And so it's the first part of your question, is it transparent and easy to understand? It is. Does the methodology create opportunities for efficiency and economy? The methodology itself does. I believe it does, apart from the rate. So just the methodology itself is easy for us because we bill so much Medicare that it's just a copying of the way that the services are billed for Medicare is how they're billed to MaineCare. Of course, our commercial payers have different methodologies, but since we already have to follow Medicare, the MaineCare methodologies are transparent and easy for us to understand. And they also cross over well from a Medicare to a MaineCare for the dual eligibles. Those claims cross over wonderfully because it is the same methodology. Where we run into some problems with methodology is when it is Medicaid after a commercial payer. And as you know, most of the commercial payers are high deductible, so there's always deductibles going to MaineCare. Those claims don't cross over. They have to be manually entered, and EOBs have to be attached, even though we electronically send you those claims. So we electronically send you the claims secondary just like we do with Medicare. However, with the commercial payers, there's bundling and unbundling of lab services, so there's rolling and unrolling, and then we need to actually go into the MIMS portal and resubmit those, scan and copy the paper EOBs, and then upload those. And so I think that part of the methodology in terms of billing for a secondary claim is extremely burdensome, very costly. And what else? There were some other things I wanted to talk about. Oh, they typically bundle, da-da-da. Does the methodology require you to bill for minutes for service or hours? Yeah, I think that would be my biggest takeaway for a laboratory. It is that ability to submit secondary claims electronically. We post everything electronically, send it electronically secondary, so what you are getting is what is in our billing system. Yet for some reason, MaineCare still needs to have a paper EOB scanned, uploaded, all this manual entry, and that is extremely burdensome. Let's see what else. Services that are bundled. Again, we bundle for commercial payers, we unbundle for Medicare and Medicaid. So all of our commercial claims that are where MaineCare is secondary payer, those are the methodology challenges. Our billing system will roll and unroll based on that, but MaineCare has problems receiving those electronic secondaries. And I get it. It's an accountability thing and whatnot, but that does create some problems. So the current methodology works fairly well. When it talks about, I think I have more to talk about maybe in the next question. So that's all I'll say for now. Thank you.
Okay, great. Thanks so much, Liz. Are there any other people? I know that if you're having trouble raising your hand, the symbol is a little tiny, kind of looks like a hand next to one that looks like a megaphone that's feedback right above what should be your chat panel. So if you aren't able to find your raised hand, that's where it lives. Are there any other people who perhaps a call-in who can't raise their hand or can't chat to us that would like to speak on this question before we move to the next?
And Julia, before we move on, this is Peter. This is exactly what we were hoping for. So those who have spoken so far, thanks very much. A little bit more just in terms of the general structure of the meeting. We say half an hour per topic, just because we want to make sure that we don't run over on one topic, and at the expense of another. If it turns out that we finish up early, we can come back to, topics that we had talked about previously. If folks who have already, and then also, folks who have spoken on one topic are more than welcome to speak again on other topics. And even if further down the meeting, you think of something that you forgot to say before, please don't be shy about raising your hand and saying it again. One of the advantages of town hall type meetings is that sometimes a comment made by one person can, give somebody else an idea about something they hadn't thought of saying previously. So the more folks, the more folks share, the more it'll just spur more input, and the more input we get, the better. Folks have been waiting for us to do this process for a while, and this is it. It's sort of a speak now or forever, hold your peace situation. Granted, as David had mentioned at the top of the meeting, also please feel free to send us any comments at any time at that email address. But we really do encourage you to speak during this session, precisely because it can be a catalyst for comments from others and just really generate ideas. And then just for anybody thinking about, oh, it's strange that we have imaging and dental at the same day. Is it a little weird to be jumping from one to the other? We thought long and hard about that. What was the best way to structure these things? And it was interesting to hear, the person, when you go, here's how we do dental, but then you hear lab where it's just keyed right off of MaineCare. And so having providers of vastly different services hear from one another about how we pay for those different services, because there isn't necessarily a reason that the folks who provide dental would know how we pay for lab or vice versa. Hearing that variety in how we pay for different services, again, could also be a catalyst for you to think of things you might not otherwise think of. So I just wanted to make those points, and thanks to everybody who's talked so far, and we hope for a lot more input as we move on. Julia.
Great. So I did see that Angela, that you had a question. I wanted to make sure that if you did want to speak, that we gave you that opportunity, because I know you were looking for the hand.
Yes. Hi, Julia. Can you hear me?
Yes, we can.
Okay, great. Sorry, I have a hard phone line and the internet. No, thank you for the opportunity. My name is Angela Westhoff with the Maine Dental Association. I don't have a lot to add. I think Dr. Wallawender and Dr. Desjardins really covered a lot of what we're hearing from our provider members on this question. Dr. Desjardins is on our board of directors, and we've talked a lot with both nonprofit dental clinics and private practice dental offices trying to collect feedback for this meeting. I think the only other thing, which isn't necessarily payment methodology driven, but it does relate to the first bullet, is just some new providers tell us they have difficulty enrolling to become a MaineCare provider. And I also heard from one office that while they had been a MaineCare provider for many years, I don't know if it was specifically due to recredentialing, but they had to submit some additional paperwork. They submitted the paperwork, some box wasn't checked or some form was incorrect, so it was sent back to them. They tried to correct it, and for whatever reason, it just fell apart. So unfortunately, I think sometimes we lose dental providers because of the administrative burden of enrolling or re-enrolling. So I just wanted to make that comment. It's not necessarily payment related, but it's about getting them in the system. So thank you.
Great. So Grace, if you could flip to the next slide, we'll go ahead and start the discussion for question number 2. So this is really looking at whether the what type of incentives the payment methodology creates. Does the way that it's structured now currently create an incentive to have quality of care? Does it provide access to care, support primary and preventative care, the integration of care, care coordination, how members use services, and the avoidance of abuse and fraud? So we'll go ahead and start looking for hands to go up for this question.
Okay, thank you. I'm going to start again with Jeff.
Hi, thank you. So I won't introduce myself again, but I don't know if I mentioned I am a dentist as well, so I do treat patients every day as well as being the executive director. So I'll be brief again, but when we talk about the quality of care, and I'm going to speak more generally towards adults and children, but the payment methodology really is pointed towards end-stage disease treatment for adults and heavily weighted towards treatment instead of preventive. And as far as access to care for MaineCare patients, especially adults, it's extremely restricted. Most providers are not accepting MaineCare, and those that do really limit their practice to a small amount certain days. And this places a huge burden of care on the offices that do. For example, our payer mix is over 50% MaineCare patients, and a lot of them are emergency services only. And, when you talk about access and quality of care, we don't even have the funds to hire a single manager for any of our offices. And once again, the burden on the benefit is us explaining it to the patients, and we don't get reimbursed for that. So, really looking at how, not just what it's paid, but how it's paid, and what services are covered, I think is extremely important when you talk about all of these primary and preventive care and integration of care and coordination. So I'll leave it for some of the other dentists to talk more about that and some of the other people, but certainly that is a huge, huge issue. Thank you.
Great. So, Jillian, you want to go ahead with the next speaker?
Yes, so I'm going to unmute all the call-in users 'cause I don't see any other hands. Liz or any other call-in user, do you have any comments?
Hi, can you hear me?
Yes.
This is Liz again at the laboratory. And I just wanted to comment on this question number 2. I think most of the bullets are provided based on the current methodology. However, I would like to point out a couple of things. Access to care, I feel the methodology itself isn't limiting access to care per se for laboratory services, but the rates themselves are. And so just to give you an idea, we curry all over the state of Maine, and mostly in northern Maine, to a lot of these small FQHCs and doctors' offices that are really in rural areas. And the members have a hard time just getting to their doctor's appointments, let alone going to, okay, here's a lab slot, go to your local hospital. Well, your local hospital could be an hour away. It could be, just not feasible. It's also much more expensive than an independent laboratory services. And so we have very high courier expenses going to all these rural places in the state of Maine to pick up samples and run the lab tests and interface those tests with all these different billing systems and all these different provider offices. So it's not so much the payment methodology that is reducing access of care, but frankly the rates, but we'll talk about that on a different day, I understand. So I do think it's not creating an incentive for access to care, because it actually, based on what we're getting paid and then based on the cost to curry to all of these different far-flung locations, it gets to the point where we may have to reduce our route at some point if there's, it's costing us more to do it than it is to not do it. And then the coordination of care, I'd like to talk about just a little bit. I know I'm on the MaineCare listserv, so I see everything, and I've gotten lots of information on all the good services that we are providing to reduce substance abuse in the state, which is great. But it doesn't seem like when you change a policy, you don't, or maybe not thinking comprehensively about all the services that would then be connected to that. So the increase on the substance abuse services throughout the state, which are greatly needed, you also then have limits on the number of urine drug screens. You have limits on different testing, and then it creates this, okay, so we're gonna treat all of these patients, so we want them to get well, and we want them to have medication assistance, and blah blah blah. But we're going to limit the testing that helps the physician be able to manage that medication assistance, and also be able to manage, just again, like maybe abuse of maybe street drugs or whatever the issue is. I'm just using that as an example. But when it comes to care coordination, lab services are a big part of care coordination. And so anytime that there is an increase in services in one area of the medical community, I think it needs to be thought of downstream. Okay, what would those providers then need in their toolbox to actually work with these individuals and to get these people well? And so I think there's like a little bit of disconnect as far as we're going to open up, more and more and more of services for these types of individuals, but then you forget about all the other things that they may need. And this could fall in line with imaging. It could fall in line with dental care. It could fall in line with everything. But, it's not like it's just put out in these little pieces that aren't comprehensively tied together. So when you talk about care coordination, you need to talk about everything in terms of how it coordinates back to the primary care or to the specialist or the pain manager that's working with these members. So that's all I had to say about that. Thank you for your time.
Thank you, Liz. It looks like we've got one more hand here. So Norma, you are ready to go.
Hi. And so I would like to mention that I practiced in private practice for over 20 years and then moved on to nonprofits, starting a clinic here for kids who needed the dental care in Aroostook County. And I do feel like with the 0 to 21 age group, we are able to provide really good quality of care here at St. Apollonia Dental Clinic. But part of that is because we do receive a lot of generous grants from private foundations as well. And if we see just about 70% of our patient base is MaineCare insured. And we strive to provide good quality care. When I'm thinking about all of the dentists in Aroostook County and all over the state of Maine, actually, a big issue, I have to be honest, a big issue with access to care is the very low reimbursement rate. And I know we're not going to be talking about that today, but I did want to mention it. And so that is a big hindrance to the access issue. It adds to the access issue. As far as primary and preventive care, unfortunately, the payment methodology, I don't think creates the right incentive for primary and preventive care for adults. And I do believe that oral health care and oral health wellness is a big part of primary care. Our patients who come in, whether they're young or old or whatever age, part of the care coordination we do, a big part of the care coordination that we do that is not one bit of it reimbursed, is trying to help people get to their appointments. And that means sending them to resources, Logisticare or the Aroostook Regional Transportation System, some way for getting, having transportation to come into their appointments. Travel and transportation is a big issue. Reliable transportation is a big issue. And as providers, we help them so much with that and spend quite a bit of time. And of course, it's not one bit reimbursable, the time that we spend doing that. I don't know what is meant by the question of avoidance of abuse and fraud. I don't know what you're wondering about there. Is it on the part of members or is it on the part of providers? I don't know what's meant.
So yeah, this really is, and I think you touched on this a little bit before with the bundling, unbundling. We don't report it in the way that the service is provided per tooth. And so if it's accidentally unbundled incorrectly and it doesn't match what was done, that's one of those. So I think you did address that actually in your first comments, that specific one. And I believe we have another hand that has gone up. Correct, Jillian?
Yes. Becca, I hope I unmuted you. I think you're one of the call-in users.
Yes, I'm on the phone. Can you hear me?
Yes, we can.
Okay, great. I'm sorry. I can't see a way to turn the video on. I'm Becca Matisovich with the Partnership for Children's Oral Health. And sorry, I'm getting a lot of background. And I'm not a provider. So I just wanted to speak very briefly about some of the things that I hear from providers, because we do a lot of convening of conversations and brainstorming and troubleshooting. Dr. Desjardins beat me to the point on the care management, because that is definitely a gap that we hear a lot about, and both from the community side and from the provider side. And then the other point I wanted to make was about this bullet around primary and preventive care, and especially for very young women, young children as well, that that access to oral health care often starts in the primary care provider's office, and there's really no reason that primary care providers shouldn't be able to do a lot more around prevention of dental disease and good promotion of good oral health. But the coding system makes that an extra challenge, because primary care providers' offices are not used to billing D codes and often are very unfamiliar with the dental code system. And so I think it's pretty daunting for some of them. If they're FQHCs, they may already be billing both, so that may be a little bit different. But for primary care providers' offices that are not typically billing D codes, I think it creates some barriers to thinking about how to provide that preventive care in the oral health realm. And it may not be obvious how to do it through CBT codes. I know there's a couple of exceptions that have been worked on with a lot of effort over the years. Oral health assessments can be billed for children under 3, and fluoride varnish can be billed through either a CBT code or a D code, but that's about it. And otherwise, I think there's a lot of challenges in that realm. And I think care coordination really applies on both sides, that we need a lot more in terms of, and that would contribute to quality and access as well, if both sides were able to have the support for care coordination. Thank you for the opportunity to speak.
Great, thank you very much. I am not seeing any other hands. Are you, Jillian? Is there anyone else who wants to speak on this question who has not done so? Okay, not hearing any. I think we can move on to the next question, number 3. So this is really about looking at your payment and determining whether your payment methodology, and determining whether it's equitable within services delivered by other provider groups. So looking at how fee schedules are determined and updated, the administrative burden, incentives for quality and access? Are all or most providers within your service area treated equitably in terms of payment methodology, meaning that everyone is sort of treated the same and that there's not one provider in your service area that appears to have different, be treated differently? And we'll go ahead and start with the comments. Jillian, I'll let you manage that part.
Okay, so the first hand I saw up was Norma.
Hi. So I guess I'm curious. I have a couple. I'm wondering, how would we know? Like, we just know dental. Are you asking us to compare dental to primary care or to labs, or I'm not sure what's. I do know that the last time the fee schedule for dental was updated was in 1991, I believe. So that's 30 years, and so I don't think that's equitable. I don't know when others are updated. I don't know how I would know what other providers are dealing with.
So within dental, though, are there any providers within that are providing dental services that have been updated more or less frequently, or codes added more or less frequently, even within the realm of dental services? Are
Okay.
Does that make sense?
Okay. Well, FQHCs are reimbursed differently, but of course that's a federal issue. But that's one example. I know there was an update, I think at one point for orthodontics and or for oral surgery codes. But I don't know why we wouldn't want that to be the case. Like, if it's okay if somebody else has an update, but in general, should there be an update for all of dental? Thank you.
Okay, thank you. Next person I have is Jeff.
Good morning again. So I want to say I strongly do not believe it's equitable amongst several different groups within dental and I think beyond dental. When we compare ourselves to anyone in private practice, we look at insurances such as Northeast Delta Dental, and every year they look at their fees and will typically do for example, a 3% increase in their fee. They look at the fees of what other insurance companies are doing to make sure they're at a certain level. And they do this on a yearly basis, not once every 30 years. So, I do think that the equity there between what nonprofits who are seeing a majority of MaineCare patients, or any provider who sees MaineCare, has a huge imbalance to what their private practice counterparts have. In the methodology for the reimbursement is just huge. FQHCs will also get their reimbursement up depending on the service area that they're in. So if they get an enhanced rate depending on the population that they see for a per encounter basis, so they have a much more sustainable model than, for example, someone treating MaineCare adults. And then when we compare it to other groups, I can tell you when I go to some, offices that they have managers, they have enough staff to, so I would assume that their encounter rate is enough that they're able to afford these things. But, I'm the executive director for, 6 offices, and I still have to practice full time in order for us to not close. We're not able to have managers. We're not able to have enough assistants, front desk, that type of thing. So when I look at other practices, I do see that they have enough staff at least, and they're able to retain their staff, and we're not. So I do see that as a huge, huge inequity. When we look at the administrative burden, I'll relate back that we're the ones explaining the benefit to patients. That's an administrative burden on our end. So it's a huge disparity in my view. Thank you.
Great, thank you very much. I'm seeing some hands that look like they might still have been up for question 2, or maybe they're also up for 3. So if you want to undo your hand, if you don't want to speak on this, so that we know whoever's left still has their hand up.
Okay, thank you. So Liz, looks like you've got your hand up.
Yes, hi. I would like to speak on this question. The payment methodology for services provided within our service area, I think the way the fee schedules are determined and updated is an area that needs a lot of work. I don't feel that our fee schedules are updated, like the gentleman that just spoke had talked about, years and years and years.
Liz, I think we may have lost you. I'm not hearing anything. Is anyone else?
No, I'm sending a message to Liz now to let her know that we might have lost her. She might need to call back in.
Okay.
Okay. I guess in the meantime, I think Becca, I believe your hand is up.
Yep, thank you. Yep, Becca Matisovich, Partnership for Children's Oral Health. And I just wanted to make a couple quick comments. I think, as someone who has looked across both the healthcare world and the dental world, which many folks in the dental world don't have the opportunity to do, I just wanted to point out that, Dr. Wallender's comments about the distinction between sort of private practices and nonprofit practices is something that you hear in the dental world that you don't necessarily hear in the healthcare world. And I think that part of the reason for that reflects these 3 bullets that we have ended up with, having to have nonprofit practices that focus on serving MaineCare patients as a large part of their patient population, because the fee schedules are not determined equitably and updated frequently, because the administrative burden is high and because the incentives for quality and access are challenging or just aren't there. So I definitely think this is an area that needs digging into. And one other sort of specific point is that there are ways in which public health and independent practice hygienists are delivering services in school and community settings that can increase access for kids that can't get to a dental home. And sometimes there is extra administrative burden, or there's not inequity in the fees in the sense that the fees are different for the same services, but there's some other like extra forms that are required for certain things, and just like sort of specific wrinkles in the billing that make the administrative burden higher for providing the services, particularly in sort of school and community settings. And then I think that applies to primary care settings as well, potentially reflecting my last comment.
Great, thank you so much. Did we lose Liz entirely? Or no, maybe she's back.
Hi, can you hear me?
Yes, we can.
I'm sorry, my phone, I don't know if it died or it dropped. Yeah, I just wanted to talk about administrative burden a little bit. you know, historically there were not like prior authorizations for lab services. If a physician ordered and signed the order for lab work, it was, you know, it's either something you're going to pay or you're not going to pay. So administrative burden is quite high at the moment with prior authorizations, and expecting prior authorizations before services are performed, when many times the providers have the patients in the office. The patients do not have good transportation. They're not going to drive an hour to a local hospital. They're not going to go home and call to see if the service they're about to have done needs a prior authorization. The physician just wants the best care possible. And if what they have decided is a test that needs to be done on this patient, they're going to draw the blood or collect the specimen. And, you know, as an independent laboratory, at least I would say 70% of the time we do not see the patient. We get a specimen. We get a specimen with a physician's order, and the clock is ticking on that specimen. The specimen needs to be processed. It needs to be processed. The results need to be resulted back as quickly as possible so that the provider can provide the correct quality of care. So laboratories do not stop with look at each specimen and say, oh, what kind of insurance does this patient have? And oh, we're going to need they don't do that. They're in the laboratory clinical world. They have a specimen that has an order signed by a physician, and they are going to process it. That is how it works. So on the back end, we get denials from MaineCare that say, oh, this service didn't have a prior authorization. Well, it's not something that's in our normal queue of work to begin with. And then it's already been a week to 2 weeks at this point. And then MaineCare is stating that they will not do backdated authorizations. So essentially, the lab is paying for all of that laboratory work that is being done on MaineCare members. And we have specialty labs across the country that we send some of these specimens to, which means we, affiliated lab, get a bill from that specialty laboratory, and we have to pay that bill. So not only are we not getting reimbursed, we're actually paying out of our pocket for those member services. So I think any form of prior authorizations on laboratory services for independent clinical laboratories is a huge administrative burden, and I also think it's just completely wrong. So that's all I had to say about that. Thank you so much.
Great. Thank you. So I'm seeing hands that were up and new hands that have come up. So I just wanted to make sure once you have spoken and you don't want to speak again, please put your hand down so I'm not recalling on people.
Okay, next up, it looks like we have Norma.
Hi. So I think we're kind of hearing a theme of what we're experiencing, and with the MaineCare members is that MaineCare members or members who have MaineCare have oftentimes additional burdens in their lives that helps prevent them from getting to appointments and that sort of thing. And so as providers, we do have to spend a lot more time with MaineCare members trying to help coordinate that care. And so part of why things aren't equitable is that the patients who need more of our time and we're spending more time with, whether it's administrative or sometimes it is clinical, trying to explain things in the chair, are the ones that we receive the very least for as far as providing services. And just the fact that they qualify for MaineCare means that there are more needs that need to be met, that have to be met. And so it's hard to think of equity when we're already starting at a very low point and receiving the lowest rate of pay that we do. So I just feel like that's part of a theme of what we're hearing here. Thank you.
Great, thank you. And I think the last hand we have up
We should be actually receiving more.
is Angela. Is that correct?
Yes.
Okay.
Yes. Hi, Julia. Somebody had mentioned prior authorizations and administrative burdens, and it actually sparked a memory when I was talking with some dentists collecting notes and feedback for this meeting. I did have a story, and I won't tell it, but I'll just summarize it really quickly. So one dentist shared with me a process trying to get dentures made for a MaineCare patient. And so while it's very specific, I think it illustrates the administrative burden. So dentures are covered service, but only when prior authorized by the department, and it requires written documentation from the patient's physician outlining the reasons why the dentures are medically necessary. And so this dental office could not, for the life of them, reach this patient's primary care provider, and the person was, suffering from not being able to chew food and significant weight loss, so clearly met the definition of medical necessity in statute. And so the dentist actually had to drive to the doctor's office to physically place the form there to get the signature. So that kind of administrative burden is really time consuming, and I think it's confusing to the medical providers who are like, why do I have to sign this? So I think that's just an unfortunate example, but it is illustrative of, barriers to care. So I just wanted to chime in on that, but that's it. Thanks.
Great, thank you so much. So are there any other, before we move on to question number 4, sort of last call for question number 3, if there's anyone who has not spoken who would like to, please raise your hand. Okay, not seeing any additional hands. If we want to move on to the next question number 4. So this is really getting back to the value-based purchasing that David talked about at the beginning of the presentation. And is the methodology for your service area consistent with value-based purchasing? Is it consistent with any other value-based purchasing approaches that you have in place through other payers? So if someone has, another payer has a value-based initiative that you think would be able to work that MaineCare isn't utilizing? And then the second, are there administrative requirements, some of which we've talked about, coding, billing, reimbursement, that are burdensome? And I know that we've actually talked about this in some of the other questions, so this would be any additional ones that have occurred to you that we haven't already discussed that are burdensome. And then if you feel, and then any other value-based initiatives that you would like to share. So we'll go ahead and open it up to hands. So please raise your hand again if you would like to speak.
Okay, I see a hand for Jeff, if you want to go ahead.
So I think you can probably tell by now that the dental reimbursement is completely fee for service. It's not value based. It's really not in that realm at all. One of the other things I don't know if we mentioned too much is that, when you have a member who has very little going on, who just needs, routine care, that's not a covered service. So, but someone who is not taking care of their teeth, not doing the right thing for our emergency-based service, they do get, a disproportionate amount of dental care that's covered under the current Medicaid benefit, which is I don't believe fair or equitable to the MaineCare members themselves. And I think this is probably more a legislative change versus a MaineCare methodology rate change, but certainly something that could be looked at for adults. And one other, back to the prior authorization thing, when we talk about two things here, actually. Number one, when a MaineCare service isn't covered for an adult, we have to inform them ahead of time, and we typically need it written, because if they challenge it, according to the MaineCare services, we cannot bill them for it. Even if we did tell them, we document it, they can still challenge that, and we are not able to bill them for it. So we could potentially do the service and have someone swindle us out of, the work that we did, creating a further inequity. But when we take a special needs adult to the operating room, they are emergency services only. We're not able to see what they need done as far as treatment, so we're not able to inform them ahead of time what needs to be done. So if it's not a MaineCare covered service, we're not allowed to bill them for it. And in addition, almost every single one of them, because they haven't had cleanings in at least 5 years, usually more, they need scaling and root planing, which we need a prior authorization for. And if we don't have that prior authorization in by 4 o'clock that day, we don't get reimbursed for it. And I rarely finish the operating room by 4 o'clock, and I'm able to submit all of the necessary materials, which include full set of x-rays, periodontal probing. We just don't get paid for it. And then once again, that is when you're spending, having a dentist and an assistant all day at the operating room, and you're bringing back $200 for the day, you're going to go out of business pretty quick. So, but there's nowhere else for it to be done. So once again, the burden's being placed on the nonprofit heavy MaineCare providers. So that's just one additional thing. Thank you.
Great, thank you very much. Not seeing any more hands up. So I think one of the things, if you have not are able to raise your hand, you can chat to us, or you can type in something in the QA so that we can unmute you that way. If you can't figure out where the little hand is, I know it's not easy on the WebEx to see that.
Okay, great. I'm gonna just unmute kind of a batch of people at a time to see if anyone has any comments. So I've got Albert, Anne. Any comments there?
No, I'm pretty new here at UNE's College of Dental Medicine, and so I'm just soaking in all this information. Thank you, though.
Okay, great. Okay, and then I'm going to go to the B's next. So, Barbara, Beth, Bonnie.
I don't have anything to add to what's been already said. Thank you.
Okay. Let's see here. So I've got Corinne, Daniel, Julie. There on that one. Okay, not hearing anything. Then Karen, Linda, and I know we've heard from Norma and Liz, but if you guys want to raise your hand, let me know. And Stephanie and Tom. Any comments? And you can just say silent if you don't have a comment, and if I don't hear anything, I'll assume you don't have one. Okay, I don't see anything, Julia. I think I went through everyone's name here.
Okay, great. So our next slide, let me go to the next one, please. We did want to reiterate that you can submit any written comments to us at the rate setting eval at maine.gov if you think of something after the fact, or we're having technical issues and couldn't say anything aloud during this time. We will absolutely look at all of the written submissions that we get. We thank you very much for giving us your time today and walking us through these. Your comments were very helpful to us, and we really appreciate that you took the time this morning to devote to this. If there's anything else anyone would like to end with, please don't hesitate to raise your hand, and we have some time that we can take some other comments if there are any.
Okay, it looks like I've got a couple hands here just to close out the process. First one I saw go up was Jeff.
Hi, I just wanted to thank you guys for listening and really trying to figure out what's going on with the system and any difficulties for our patients, and really caring about the process. So thank you guys for that. And I hope you can see that from all the dental providers who spoke today, that there is a real problem. And there's quite a few people who have given us, Angela from the MDA and Norma and myself comments, and then Becca comments to relay to you. But there's a lot of, support in the community for change. So thank you guys.
Okay, thank you, Jeff. Next I have Liz.
Yes, hi, can you hear me?
Yes.
I did have a question. I was reading through the materials, and it says that they were going to be comparing services with commercial health plans, Medicare, and payments used by other state Medicaid programs. Would you be able to give us a list of what those states are? And if you are in fact going to be comparing your aid rates against states in New England.
So that we do tend to focus when we do the benchmarking on states that are geographically relevant to the states we're looking at, recognizing that things like salary costs and cost of living are obviously more similar in the region than trying to compare you to something on the West Coast. So yes, we are looking at those. I think that I can look at seeing if we can provide you the list of that. I don't have them on me right now for this call, but we can speak internally and see if we can get you that information.
That would be great. Thank you.
And then Norma.
Hi, I just wanted to, Jeff beat me to it. I just wanted to express our gratitude and thanks for including us in this call. We appreciate the opportunity to speak up a little bit and to give some input. And I look forward to the next step in the process. So thank you very much.
Great. Well, thank you, everyone. I don't see any other hands up. So we're ending a bit early today. Thank you all of you again, once again, for coming and speaking to us. I hope you have the rest of your day goes just as well. Thank you.
Thank you.